All right, we're going to go ahead and get started. I know many of you are grabbing food, and that's totally fine. Just grab food and come forward. But because it's a live case transmission and there's limited time, we're going to go ahead and proceed. We have a great panel here. We have Kate Kearney from Seattle. We got Jason Wilmoth from Oregon. We got Carlos Mena, who's going to be here in support of his colleagues who are transmitting from Yale. As you know, this is a symposium sponsored by Boston Scientific. We're going to keep the commentary broad, though, because I think they're general illustrative principles that'll come across through these cases in particular, both the first stage of it as well as the current stage of it. That'll be really, I think, helpful for those that are interested in doing these types of complicated cases. So with that, I think we're going to go to the, I think there's an opening video, and then have the Yale team present.
It's okay. I say live from New Haven. It's Thursday afternoon.
Hey guys, how's it going?
Pretty good.
So we're really excited to see what you guys have in store for us today, and maybe if you want to just sort of introduce yourselves and take us through what the case is going to be. And the way we'll do this is there's a little bit of a delay in the transmission, so it's hard to do a lot of back and forth. But what we'll do is have you present the case, maybe discuss it a little bit, and then if any time you feel like you need to start working, just go ahead and do that, and then we'll sort of talk over you. And if you're making comments, we'll generally stop and let you say what you need to do. But we're really excited.
Great. That's great. Thanks very much. Let me Okay, let me introduce the team. I'm Glenn Henry.
Steve Fow.
Mike Clement. And this is Dave, Ollie, Sarah, and Amanda and Lauren. So we've got an interesting case, lots of facets of it. So I think we'll get started just giving you the presentation of the patient and what we've done so far. So 79-year-old, very petite female. She's got a lot of shortness of breath, and she has a long history of interstitial lung disease with an overlap syndrome. She started her cardiac history in 2012. She presented with shortness of breath, ultimately underwent catheterization leading to bypass. She had vein grafts to both her LAD and right coronary. The lima was felt not usable at that point, and the circumflex was felt to be too small to graft and went to a visibly scarred region on the infralateral wall. No hypertension or diabetes, and she's a remote smoker. Next. So pulmonary function tests are important here because of her lung disease. And of note, her diffusion capacity is significantly reduced to 9%. However, she does not desaturate. We're pretty certain it represents an ischemic equivalent.
So we're having, unfortunately, a little difficulty hearing you. It's cutting in and out a little bit.
So her EKG does not have anything surprising on it, little LV, no infarct pattern.
Can you hear us a little better now?
Yeah, actually, that microphone's better. So you can either try again or have the other person who's speaking.
Okay, can you hear me now?
Yep, now we're good. Perfect.
Not that I, okay. So she actually came to ART for severe right in history, had a lot of dyspnea over the last several years. Her echo shows normal LV size and ejection fraction, mild pulmonary hypertension, A nuclear stress test confirmed the fixed inferolateral defect, and she underwent catheterization a year ago at an outside institution, which we can show right now. Both of the veins are occluded. We can go. So, as you can see, tremendous amount of calcification in the left main LAD, and she's got pretty severe serial stenosis, left main, and then proximal to mid LAD there.
Yeah, I mean, this is pretty angiographically evident. Sorry, keep going ahead, and then we'll talk. Sorry, go ahead.
No, that's fine. I mean, you know, the calcium is extremely impressive here. I don't think this is a subtle finding. You can see here also circumflex occlusion and some epicardial collaterals to the distal circ from the diagonal system. And then her right coronary also had a very severe ostial narrowing that you'll see. So this was actually done preoperatively for lung transplant evaluation. They felt that her coronary disease was too severe for a lung transplant, and things kind of ended there. She went to a second institution with the same results and was sent home on chronic medical therapy. Okay.
Yeah, it's interesting, the transplant situation, because we have a very similar situation. We have an active lung transplant program, and you know, whatever the guidelines say about pre-operative coronary revascularization, frankly speaking, because of limited availability of transplant lungs, these patients often have to see multiple centers and get declined at multiple centers because they can't be revascularized. And so from a functional standpoint, it's also difficult to assess how functionally limited they are from the coronary disease because of the exertional dyspnea.
Yeah, so to that point, I had the luxury to see this lady in clinic. Actually, she's one of my patients. And the remarkable thing was exactly what you just said. It was the fact that the pulmonary team felt that the symptoms were mostly lung-related, and that the coronary artery disease perhaps was not significant. And because of her lung disease, she wasn't really a candidate for a redo bypass, which I agree, but they completely disregard the option of doing something percutaneously to both the left main LAD and the right, as Glenn is showing.
So I think you see him in clinic, so you see her in clinic, and you know, clearly there are some issues here. I also wonder with these types of cases, back in 2012 when she went for surgery, the lima being, you know, non-usable, it's interesting. The surgeons actually don't do cines of what's going on during the operating room, and often unusable lima equals transected lima, and there was a problem during the case. But with two veins, I mean, honestly, at that time in this anatomy, one could argue that with good technique, good operators, percutaneous revascularization might have been entertained at that point as well. So tell us, well, you know, what your plans are for today and what you've done already and how you formulated this case.
Yeah, so we went and met her and sat down and went through things at length with her in the office, talked about the options. She's pretty petite, and you know, the options for mechanical support are not great. We did do an angiogram today. We can show you her vessel caliber. So we settled on a staged procedure to do the ostial right first, and then the left main and LAD second. That also gives us an opportunity to confirm the angiogram, which as of now is about 16 months old. So if you want to go to the next, you can see we did a couple of things. You know, we ran through a syntax score and precise DAPT and things like that, if that's of interest to people there. But her syntax score is 30, so clearly it's higher risk. Next. You know, her DAPT risk calculator suggests that she can be prolonged for antiplatelet therapy. I will say that she is on a number of immunosuppressants as well as prednisone for her lung disease, which doesn't figure directly into this. So something that we need to be aware of.
Yeah, and I would say that among risk factors for bleeding, that chronic steroids is a huge one. And just because the score doesn't capture it doesn't mean the patient's not at risk for it.
Absolutely. Absolutely. So we can go next. So this is how we set things up. Two procedures. First, diagnostic and do the right if things are as planned. Second, to do atherectomy given the extreme density of calcification. She's not a candidate for an a priori myocardial support. We did put in a safety sheet just to be certain, to have some backup in case anything should happen. Next. Next. So we went radial, left radial. You can see here she still has pretty much the same anatomy, pretty severe ostial right coronary. There's a fair amount of calcium around the area of the right. As Jay pointed out, the tremendous calcification in the left system, it's not the vessel we're injecting, but almost don't need to inject it. And then we took 2 pictures of the left system, and basically it's unchanged from past. Next.
So maybe if it's okay with you,
So what we did is,
yeah, so go ahead. That's
Yeah.
fine. I was going to ask the panel really quickly, you have this anatomy,
Sure.
Maybe just real quick, how would you approach this? Which one you do first? How do you address these issues of support, no support? I don't know, Jason and Kate, tell us what you think.
Yeah, I think the approach of getting the right coronary artery fixed first is helpful, and I think it can mitigate potentially the need for hemodynamic support. The reasons for hemodynamic support in general have become less about what the coronary anatomy looks like and more about what the patient presentation is and their hemodynamics are. And so if you have a patient that presents with acute systolic heart failure or an end-STEMI and they have anatomy like this, particularly with a deep depressed EF, elevated filling pressures, I'm going to be much more likely to use support. But in a patient that is stable, has the right coronary artery revascularized, has a left system, even though you're in the left main, you're not dealing with major bifurcations. Even with the use of atherectomy, I think you can get by without needing hemodynamic support. I think this is obviously a case where I'd probably have access into the iliac and evaluate the iliac so I have a backup strategy that I can use quickly if the patient did decompensate. But assuming that the patient's hemodynamics are favorable, the LV function is reasonable, I think this is a case where you could easily go through without the need of hemodynamic support.
Yeah, I think we're going to let you guys keep going because I know you have to work and there's limited time, but we'll talk more about that as you're doing your work. So you treated the right. Did you need atherectomy on the right? Go ahead.
So, well, we did it. Yeah, why don't you keep going with the PowerPoint and next. There you go. So this is the ibis of the ostial right. So pretty thick shelf of calcium, but 180 degrees or less. The vessel caliber is pretty big there, but you can see it's quite tight. Next. Distal reference is an excellent vessel. Not a lot of disease at all. Next.
So really quick for the audience, those just want to give me 1 second. Those images, the distal reference determines the size of the vessel. You just measure across it and you'll know what the size is. And that ostial image, because the calcium was less than 180 degrees, suggests that you don't have to do atherectomy. You could prep it with a specialty balloon or a non-compliant balloon and get a good result. And is that what you, it seems that's what you ended up doing because I saw a balloon inflation. Go ahead.
Absolutely. So pre-dilation, and then we used a Wolverine, as you said, a specialty balloon. This is at 3.5 going up. We can go next. Very careful to keep the guide well positioned outside the ostium, but at the vessel. And here's a stent going in, and we can go next. And then we post-dilated it, did an osteal flash to flare the distal, and here's the final result. You can actually see the stent flaring out into the aorta there. So very nice results. Some IBIS to confirm what we see angiographically. Excellent luminal area. And this is an interesting picture. If you look kind of between 10 and 1 o'clock, you can see that sheaf of calcium that was much more prevalent when the vessel was much smaller. And you can see fractures in that and full vessel expansion there.
So that's great. So why don't we let you work? I think we started talking a little bit about this issue of support. Frankly, in our lab, with the right revascularized normal EF and an EDP that started off low, we wouldn't even put in a sheath in the iliac. We've actually had more issues with a 4-French sheath getting kinked and bleeding around it and that sort of thing, and we're pretty facile at ultrasound-guided access that we would just proceed without support. The reason I make that point is because there is this misnomer, I think, out there, especially in the U.S., that if you're doing a left main, you need to use hemodynamic support. In fact, 25% of cases in NCDR are done that way, and hopefully we'll show in this demonstration that that's not necessary for cases like this, which are done thoughtfully with adequate preparation of the right side as well, for all the reasons Jason mentioned.
I think if you don't have a good definition of the disease in the iliacs, and particularly if she's got a history of peripheral vascular disease, I think you want to know that. You just want to make sure that if you get into a situation where the patient is decompensating quickly, that you can quickly get an Impella in. Getting an Impella in under 5 minutes is relatively easy if they don't have peripheral arterial disease. But if they have significant peripheral arterial disease, aortic stenosis, those are things that you want to be prepared for early so you can get through or get an Impella in quickly if the patient did decompensate.
I couldn't agree more, and oftentimes we would do upfront ultrasounds, and this is a perfect picture and example. It's being prepared so you know how to mitigate if things happen. Because the EF is fine, you have more time because the patient has more reserve. But if you don't have iliacs, you have no reserve, and there's no bailout.
Right, so as you can see here on the picture, we did that, and there's not much disease there at all, but the size is really suboptimal. So we're actually all set up here. What we did is we took a workhorse wire and a microcatheter down the LAD, as we've been talking to you here, flipped that out for a floppy roto wire. We brought a 1.5 burr up to the guide tip. We're going to need to start rotoing from the guide into the left main, as you can see. I'm going to go to the next picture. And what we did is pulled our guide up a little bit, made it coaxial, got the rotover right at the tip of the guide now, took all the tension off the roto so it's not going to jump forward, and we're all set to go.
That's great.
Show us the roto. We can see it. There you go.
And so you platformed outside the body, so good technique is you test outside of the body. What sort of speeds are you using? What burr size are you using?
We're using a 1.5 burr, and we platformed at 160. So we'll go on the slower, on the slow side. It's a lot of calcium. One can make an argument with this to even use a 1.25 burr, given the severity distally. But we elected to use a 1.5. So based on the older data, a burr size of less than 0.6 to the size of the vessel is acceptable.
I know.
Yeah, I think
so, see, the key to roto is...
Go ahead.
Go ahead. No, I was going to say, kind of a few things for roto to keep it simple is go fast, go slow, go long, go short. So go fast, keep the speed up, don't delay. Go slow, nice slow pecking motions, not rapid exchange. And go long means get all the lesion. Don't just stop at one area of calcification, prepare the whole vessel. And go short means keep your run short. So I think, that's kind of the 4 points of doing a successful roto.
Hey, Steve, I have a quick question for you. Obviously, there are different devices for atherectomy in the market, and perhaps you can comment on your thought process behind choosing one versus the other and highlight the properties of the roto in this specific case that made you decide that way.
So, Carlos, I'm an old roto guy, so you go with what you're most comfortable with and most experienced with. I think the CSI device has been great, but something like this is ideal for roto. It's a really long lesion. You just want to be able to make a channel through those angles up front there and get access to the distal LAD so you can get a nice balloon inflation.
Yeah.
So
there's a couple points that I think are worth mentioning with this case in particular, given her petite size, given her sex, given the fact that she's on chronic steroids. Not only is she at higher risk for vascular complications, which, by the way, also would lean you against using a support device in a large bore sheath, but during atherectomy in particular, there's a greater risk of perforation. And so ways you can mitigate that, number one is you can take a floppier wire. At present, the CSI only has a stiffer wire, the Viper wire, which gives you more bias. So a floppier wire would tend to avoid that. The second thing you can do is you can take a picture with the wire down to be sure you don't have dramatic wire bias, which is going to be a problem. And then if you would use a non-orbiting device, you're, as was stated, going to make a focal area where you crack calcium and then use the balloon for the rest of it. So I'm not saying specifically that one device is safer than the other, but in this particular situation, especially because you have the floppier wire, this is a very reasonable choice for what to use.
Yeah, I think it's an important point to make for the audience in particular, because at times you have all these different options, and it's always good to have an algorithm, at least in your head, as to how you make the decision between one or the other.
So the nice thing about the Roto Pro is that it gives you a lot of warnings if you're not used to using it. People who use the old device had to depend on people reading out the RPM. This shows it to you visibly, and it's easy to see, and the acoustic feedback is the same. So for somebody like myself who's been using it for probably 25 or 30 years, it's pretty much the same, but a lot easier to use.
Yeah, so I was actually going to comment on that, and I don't know if you could tell, but you don't hear anybody calling out what the decels are, what the times are, because this new console on the Roto Pro actually allows you to see that up front. It also has no foot pedal, so you still have everything in the handle with the activation in the handle. In addition, there's been people who say, oh, it's so great you don't have tanks. You still do have tanks. There's a smaller system available that can make it more user-friendly. But those are iterations, and there's still more iterations going to be made to this system based upon user feedback from the current version of the Roto Pro. Now, for the taking out part, what they've done is they've gone on Dynaglide. The left-hand thumb of the secondary operator is holding the brake to defeat it, and typically the easiest way is to advance the wire, and the thing will come out in that way. So really, the idea here is not to ablate all the plaque, it's to modify it so that then the balloons can do their work when you go back with an NC balloon and crack it at that point.
So I think one of the things that came up was burr size, Ajay, and I think one of the operators I think mentioned using a 125 burr. I would say that's the least commonly used burr in my lab. And the reason is the 125 burr has more of a bullet shape as opposed to that elliptoid shape. And it does tend to jump past calcium and get stuck. It's also one that tends to fracture, and you can dislodge the burr head from the drive shaft. And so I just don't think you get enough debulking and fracturing with that. And it comes with a cost of a little bit higher risk of complications.
So a really important thing that was just shown there is they did a test injection and you saw slow flow in the vessel. Now sometimes that can happen during the rotablation as well. From technique standpoint, especially for long runs, you do want to take test injections while you're ablating, because if you see that, then the absolute wrong thing to do is to continue to ablate. Right. What you want to do is you want to reverse the slow flow, and whether that requires vasodilators, whether it requires neosynephrine to keep the pressure up, or other things before you increase the embolic load distally. There's some cases you may even have to aspirate a little bit to get rid of some of that debris, but here now they've shown it, they'll work on doing that. Hemodynamically, the patient's fine.
Yeah, blood pressure's a little soft, but she started out pretty soft, so.
Okay.
So with slow reflow, prevention is worth an ounce of cure. And so a lot of times you want to try to predict if this is going to be a higher risk of happening. Obviously, higher burr speeds, longer runs, starting a burr in a soft plaque will oftentimes increase the risk of no reflow. So you want to be thoughtful ahead of time. And a lot of times people will pre-treat these lesions. They'll give atropine or adenosine or calcium channel blockers before the run, and oftentimes even between each run. And so, one of the other things that I noticed is when they were about halfway through the lesion, they did a test injection, had some slow flow. That may be a nice time to actually bring the burr back, give some drug, let the patient's artery breathe a little bit before you before you do more. Once you have slow flow, if you keep burring, you're almost certainly going to get no reflow, and it makes it that much harder to reestablish flow.
So what did you just give there, vasodilator-wise?
We just gave 200 of nicardipine.
Yeah.
This is a great place to use a dual lumen catheter as well, where you don't need to lose wire position. You can use the second wire port to deliver drugs into the distal bed as well. So it may not be an unreasonable thing after they switch out the microcatheter if they still can't get flow with intracoronary injections.
And sometimes you have to give fluids during this. You may give neosynephrine or other things. I personally like adenosine because it tends to be less hypotensive inducing. But the idea is to reverse this before doing further work in the vessel. So, Kate, let me ask you a question. They did not image first. Obviously, the calcium was severe, so no one's going to fault them from doing rota. Do you image these cases first? And let's say it wasn't circumferential. Might you have chosen a different strategy up front?
No.
Yeah, it's a good point. Especially as a newer operator, I think imaging just gives you so much kind of reassurance about your treatment strategy. But in a lot of these cases, you know that with that burden of calcium and the length of that, it's always worse than it even looks angiographically. So I think I also would have just gone straight to rota there. And the difficulty with trying to get your imaging catheter down and the vessel prep that needs to happen, that always makes me a lot more nervous. It's less so with rota than I think the orbital systems, but if you're ballooning and then having to do atherectomy after that, I just don't think that that's worth it. So imaging once after they've ballooned makes perfect sense to me for that. And just to comment on the 125 bird, there was a nice case presentation this morning where someone commented that the 1.5 wouldn't make a corner in a right coronary, and so they didn't want to go to the 125, but ultimately chose to there. And I think there's a number of times where just that patience of taking your time and doing a few more runs on the 1.5, a lot of times it will go, but they had a case where the 125 did get entrapped and had to deal with that mess in a perf. But anyway, so good points.
So flow looks better, and patients' hemodynamics are stable?
We're using a little pressors, but I think we're going to be fine here.
Yeah.
Step on flow.
Now, there are other techniques that you could use. You can keep the rotowire down, and you can wire with a second wire, and then do your balloon inflations. If it doesn't expand, then you can roto more. But in this particular case, with slow flow, the likelihood that anybody's going to be enthusiastic about doing any other rotoablation is going to be low. So at this point, swapping the wire with a microcatheter is a good approach.
So, Ajay, I'm just curious, in cases where you decide, where it's maybe a borderline case about whether you're going to use hemodynamics or not, hemodynamic support or not, do you do any intra-procedural monitoring just to kind of follow hemodynamics other than just their systolic pressure? I don't routinely put in right heart caths to monitor, but in a case where it's maybe a borderline indication for hemodynamic support, it may not be an unreasonable thing to be following their PA pressures or their wedge, because you may see some changes there before you start seeing changes in the systolic pressure.
Yeah, I mean, 100%. I think that, it's a telltale sign, and many of us have taught this during fellowship. If the patient starts coughing, they're about to go into pulmonary edema and they're going to get sick. Well, if the wedge starts rising or the PA pressure starts rising, that happens before they start coughing. So for low EF patients or patients with borderline EFs, we'll often have a right heart cath in and keep it in during the case, monitoring it continuously. For normal EF, if the EDP was fine at the beginning, I probably wouldn't. But that's a great point for when you want to think about it. I think the other point just about the imaging catheter, this case is obvious. There's a lot of calcium. But there are cases where, you're not sure. And, risk factors for severe calcification are things like post-CABG, this patient has it, severe renal disease, this patient doesn't have it, elderly age, and you really have to have your spidey sense about this. And if you start having those risk factors, then you're still on the fence. Those are good cases to image. Kate talked about crossing of catheters. The one advantage, I'm hoping we'll get to see an HD IVUS being used here, is that the big advantage of that catheter over the conventional IVUS catheter that's used in most labs in the US is crossability. You cannot drive an eagle eye catheter through heavy calcification, tortuosity, and severe disease, whereas some of these other catheters, they actually cross a lot better. And the image quality, as you'll see, is likely going to be night and day difference as well.
So what are you guys now at? What are you guys doing?
just going to image now.
And it's getting better slowly. We're gonna go down and image.
Just show that picture again. You want to image first? Yeah. Make sure there's no split.
The one challenge with imaging catheters and an HD catheter in particular is that there is more blood pooling artifacts. So if you take an HD IVUS down and the vessel flow isn't great, then it's sometimes hard to appreciate the difference between the artifact of the imaging, of the flow versus where everything else is. But you probably have enough flow at this point to sort it out. The other thing, because you have good or better distal flow, is you could balloon first and then image afterwards, but either approach is fine.
So we just wanted to, we just wanted to be clear. You can see, if you look at the angio carefully, there's a segment just distal to the calcification that runs intramyocardial, and the vessel walls there get pretty thin in general. So we just wanted to make sure where we wanted to land stuff before we started ballooning in fears of ending up in that dissecting it with a stent. So we're just going to run down really quickly and do this, and then we'll post-dilate it with a 1.5 non-compliant, a 2.5 non-compliant, excuse me.
No, I think that's great.
Did you guys test the image?
So the flow is slowly getting better.
Yep.
How much Neo show, guys?
What's the Neo? Or Levo?
I just have fluoro
To get a pressure up real quickly.
turn the image on.
So this is a rotational IVUS
We didn't
from.
hit any of the we didn't really hit any of the predictors of slow flow. We had no significant decelerations. We had no long runs. But what we did have, the one predictor I think we did have is extensive calcification. And so the burden of debris was, fairly substantial. So even the revolution here is having a difficulty getting around the corner here.
Yeah, I mean, typically you need to pre-dilate it first. And so after atherectomy, NC balloon is generally the next step to then get it. But this catheter is a rotational catheter from Volcano. Not many labs have it, but it works pretty well. The Revolution and the Refinity is a newer version. It certainly delivers better than the Eagle Eye. And these catheters, if they don't deliver, then you clearly are going to need to do dilation first.
So what balloon are you going to use, Mike, to pre-dilate that lesion?
We're going to use a 2.5 NC emerge, a 2.5 by 15.
So don't ever really make the mistake of atherectomizing and then trying to deliver a stent directly. You really should pre-dilate, and typically with an NC balloon, to make sure you have adequate expansion first. So
That's the ultimate roto regret.
yeah, that's right. It's even worse than not having used it at all.
Exactly. That's ultimate roto regret.
Okay.
So we're just putting down the balloon, and I think this will clear up shortly, and then we'll be able to image it and work on our stenting.
Fluoro, please.
What wire do you have down the LAD?
This is now a workhorse wire. We just switched out from the rotofloppy wire.
Got it.
Samurai.
It's a Samurai wire.
Fluoro?
Come back in here.
So we're trying to stay within the segments that we roto just to start with, so we don't, cause any further damage.
Fluoro?
So we'll go up to relatively low pressure, like 8 atmospheres or something, just to make sure that we get full expansion.
So just
Now,
that's
Kate-
4 atmospheres right there. Just
Kate, would
Fully
you,
expanded at 4.
what about the side branch there, the big diagonal? Would you do anything about it? What do you think?
Yeah, I think this would have been a case, because of the slow flow, I would have dropped a twin pass distally, given some drugs distally, and then on the way out, use the wire port to drop a wire out the diagonal branch.
Yeah.
It can be helpful not only to protect the diagonal branch, but also as a marker after you stent across it. You can leave it there so you're not doing a lot of pictures to find it. The other thing is it can be a helpful marker when you're trying to avoid contrast injections. if you have marker or wires in different branches, you can do a lot of intervention without, basically no contrast.
That's right. I think, honestly, in this case, with the slow flow and the LED, you have stunning in that distribution. If you lose another branch, and the likelihood of losing is low, but a big branch like that diagonal, that's when patients tend to get pretty sick. And so, in general, even though it may take some effort to get up and into it, it's always better to wire it and at least have it there as a jailed wire when doing the rest of your intervention.
I would say, however, that, if you look at that angiogram at the beginning, the osseum of that diagonal doesn't seem particularly compromised.
No, I think you're right. I think it's definitely a 110 Medina lesion, but oftentimes having it in there just to as a marker to protect and a marker to help guide where you're ballooning and stenting can be helpful.
Yeah, no, totally. The only issue, though, is that in these complicated cases, I often think that keep it simple. The more barriers and the more elements that you introduce into the equation is a setup for having more and more complications. So
yeah, I hate to be contrarian, Carlos, but I think that the part of the problem with that is that you have to look at the risk and reward of each of it. There's very little downside to wiring a branch. It's the basically $65 cost of the wire, and if you happen to lose it, yes, it's rare. The downside could be catastrophic in a high-risk case. So,
yeah, for sure.
All right, guys, so I think what we're going to do now, we've kind of got things prepared.
You're going to IVUS.
Dilated with this 2.5 balloons, a low atmosphere. It's time to see exactly what's going on.
Yeah, and that'll help give you the stent size.
Is to wire the diagonal. Give it twerker.
The other reason to do the IVUS at the post-balloon step, many people omit that, is because you want to be sure, number one, the stenting with appropriate size, but also if you see fracture in the calcium, then you know you're going to expand your stent more effectively. So you have the catheter open. There's really little downside to using it unless the patient's hemodynamically unstable. So we then do go back at that stage to sort out what's going on.
Yeah, with routine use of imaging, I think most people will find that they're going to upsize their stents at least 0.5 millimeter, but oftentimes even 1 millimeter or more. And it comes into play, particularly when you're getting up near the left main. What you don't want to do is put a 3.0 stent and then find out that the left main is really 4.5, and then you can never get your stent fully expanded. And so I think knowing that the stent characteristics, how big you can make each individual stent if you need to, and then imaging beforehand so you really avoid the trap of getting undersized stents in the left main. Anybody that thinks about putting a 3.5 or smaller stent in the left main should stop and image, because most human beings do not have 3.5 or less left mains.
Mm-hmm. Yeah, we saw that actually in our lab. There were pretty high volume operators, but we went from very spotty imaging use to pretty much over 90% use of imaging pre-stenting, and our stent size over those couple of years increased by, on average, just under 1 millimeter.
So we're with a little wire difficulty. Our plan is to image, and then prior to stenting, we'll wire that diagonal, which was our plan to start with. Some people, just as a point for you guys to talk about, have any of you used a fine cross? If you have a true bifurcation lesion, and you want to protect that, have any of you used a fine cross in the side branch and wrote it alongside it?
Yeah. So one of the challenges with doing that is you need an 8 French guide to get a fine cross next to it. The other thing is fine crosses oftentimes get ripped up by rotablator burrs. It's probably better to use a braided microcatheter. They tolerate it better. Colleague Kevin Kroos has done a number of cases with CSI next to a fine cross, and that actually works fairly well. But I've seen a couple cases where people have really mangled a fine cross with a rotablator, and so I've gone to using a Corsair catheter, and probably will end up actually going to use the new Corsair extra small because I think it'll fit better.
Yeah, I mean, it's definitely something we've heard talked about at conferences recently, but it's one that needs study. And even the fine cross or the turnpike, if you look at what it looks like afterwards, there are marks on it, and so that means we presumably have embolized things distally.
there's
So
probably some debris.
I would say that we need a little bit more study before we start doing it. And the truth is, the old-fashioned way of just doing atherectomy across a branch, you almost never lose the branch because you're debulking at that branch. So that's kind of how that I would think about it. So they're going to go back with the IVUS catheter. I think because we're in terms of a time limit, we will keep going and maybe talk a little bit about not just what we're seeing on the IVUS, but then potential stent considerations for this case, especially given some of the transplant issues that she's going to ultimately have. But I would expect this IVUS to cross more readily at this point after the pre-dil.
But I would say that even if you can't get it across that last bit, I think you're still going to get a lot of valuable information at this point, and mostly regarding sizing.
We'll just do a pullback from here.
Yeah.
It's
No, I agree.
slowly. Hold on, let's take back. Pretty close.
Yeah, you should, I think, be able to coerce it. Yeah, there you go.
That's good enough.
It's there. All right. I'm good. One.
Okay. So we're doing our pullback now in 0.5.
So with all these systems and motorized pullback, you can actually get a length measurement, which is great. But you can see how they needed to use it here because there was almost, concentric calcification down distally. We'll go through some of the measurements shortly, but there are some fractures there.
You can see the nice divot from the rotover earlier, too.
The biggest challenge folks have, I mean, how many of you use IVUS in 10% of your cases? Let's raise your hand from the audience. 20%? 30%? And then it thins out. If you don't use it enough, it becomes harder and harder to interpret the images and sort it out. If you use it routinely, then it becomes, really easy to sort out. I think the challenge in some of these cases is that this is a complex case, so there's going to be a lot of shadowing and dropout, so you have to be able to interpret in that way. But maybe if you go to the images, we can see how you make the measurements and then sort that out.
That's up at the diagonal. Yeah. So it's probably going to be close to a 4-hour at certain points in this.
Yeah, every once in a while you'll get an area where there's not a concentric shelf of calcium, and that is a good place to get those measurements.
So eccentric plaque in the left main and then coming out to the ostium there.
Okay.
But overall, it looks like most of it's in the LAD.
But that IVUS does highlight the importance of imaging all these left mains. It's critical, as Jason was saying before, to image all these lesions before you actually intervene on them to understand exactly what you're dealing with, and size is so important.
I think those pictures, good. Oh, those pictures really nicely show what you're dealing with there, but I have heard people, especially, my colleagues, people I'm graduating with from fellowship in recent years say, well, I don't want to hurt this lady. She's very high risk and fragile, so I'm not going to do atherectomy because I'm afraid of the risk associated with that. But I think it's a good example in capable hands that probably her risk of perforation and exploding a bunch of balloons in her artery would go up by not doing that.
So in terms of how to size, really simple. You go to your distal area where there's not a lot of plaque. You go to that area and basically then measure across. Typically with an IVUS, you'll kind of go media to media and discount it a little bit, and that's your vessel size distally and distal reference segment. So they're going to go, here's disease diffusely down here, so they'll probably come back a little bit more proximal to that point, or they'll want to measure here. They basically mark and go diametrically across, and they'll get a size of what the stent should be. Now that's lumen to lumen, so that's why it looks 2.0, but if you were to go sort of from 10 o'clock to 3 o'clock or measure in this segment here in that same way, I think you're gonna find this is at least a 3.0 in that mid-LAD. The calcium shelf makes it a little bit more challenging because you get dropout there, so that's why different modalities are easier to measure one way or the other. But here, if they go from there and they go to about 5 o'clock, you're sort of getting 2.7, so maybe not a 3.0, so maybe a little bit smaller.
I'd still go.
Yeah, but you can go up with the NC balloon for the pose. The other challenge here is that it depends on how far proximal you're going to get, but if you take a 2.75 stent, it may not get, depending on which stent it is, all the way up to where you need it to be in the very proximal LAD left main. So there are stent sizing charts and things like that you can sort out. This looks more 3.0 in this segment. And remember, she's immunosuppressed and small, so you might want to choose to go more size that way rather than go too big. So what were you thinking size-wise?
So, you want to answer, Glenn? I was thinking 2.75 distally, a shorter stent, and then upsize the stent from there.
Yeah, I think that's very reasonable. What's the overall length, though, you need? Can you get it with a single stent, or do you have to put in 2 stents?
No, it's more than a 38.
Okay.
Yeah, and I think one of the things...
key here is we're going to have to find a good overlap section for the stents, too. You don't want to overlap them in an area of severe disease.
And you don't
And
want
you
to
also
double
don't
jail
want to
the diagonal-
overlap them
on
over the diagonal branch or even the
The
circumflex.
So this is where the imaging can help, because it'll allow you to, instead of just guesstimating the size, you can truly measure it, and you can figure out where to be so you don't double jail the diagonal.
Between those two diagonals.
So, yeah, you guys can see here the IVUS image, the crosshairs are in the diag there. So this is right adjacent to where that big diag comes off.
Yeah.
It's pretty big up there. So we're going to put a smaller one distal and then take a nice long one. Big thing proximal.
That sounds like a good plan.
This may even be a case where you need 3 separate stents just because that distal vessel is so small, and if you're going to I don't know if you're going to want a 2.75 in that proximal LAD.
Yeah.
Yeah, I think, Jason, you're looking at a 2.5 for the distal stent, and as was said before, the key is to make sure the stent ends in an appropriate area, no distal edge dissection, not a significant burden of disease, and we can post-dilate it and make it appropriate size. So we know how big we can make it now.
And all the manufacturers have sort of dimensional capacities typically on the box. If not, there's charts. We actually have a chart in our lab that we made up that has all the different stent types and what they go up to. But I think with a 2.5, you're going to be able to get up to where you need to get, at least in the LAD, and then take a different stent more proximal to that. Maybe because we have a little bit of time, let's talk a little bit about stent choice, DAP duration, and that sort of thing. I mean, Kate, what do you think in this case? What would you use, and what would you say is the DAP duration? When can she go for her transplant? All of these are pretty relevant questions.
Yeah, all these issues come up a lot in the transplant patients, but I think there are a lot of risk scores out there, but as you highlighted nicely, they often don't capture the real issues that we're dealing with in these complex patients. So she certainly is higher risk. Most of the patients are on anticoagulation that we deal with. That's their other main risk factor. Liver, kidney disease, and things like that. So I think for our practice routinely, after 3 months, we're allowing them to drop down to single agent therapy. We've been doing that for a while, and we basically don't put anybody on, quote, triple therapy. So if they're on anticoagulation, we'll discharge them on just their warfarin and their P2Y12 inhibitor. But I think in our transplant population, we're generally giving them the 3-month window, and then after that, because they have a waiting game that they have to play anyway, so as soon as we can open that up, the better for them.
Yeah, I mean, there's more and
Certainly
more
some
emerging
data
data.
about
It used to be just retrospective data. We now at least, what stent is this you're putting in?
Great place. We're putting a 2.5 by 24 synergy.
And
Yeah.
With Synergy, at least because of the senior trial, there's some data now prospectively with 1 month DAPT and then a longer cohort of patients with ACS that had longer duration DAP. At TCT, we'll be presenting over 2,000 patients worth of data on 3-month discontinuation in patients at high bleeding risk. And so I don't have the data yet, but really looking forward to analyze that and be able to present it, which would hopefully lead to an FDA indication for shorter DAP duration with this stent. There are other stents also that will be having shorter duration of DAP therapy with presentations in the next coming year. So this idea of shorter durations is something that a lot of people are thinking about because, as Kate said, our patients bleed and they can be at higher risk. So we want to really be able to know what the optimal duration would be.
Yeah, especially with synergies. If we know that this is an issue, we often will choose synergy if we're looking for 1 or 3 months just because of the data is a little bit better on that. But I'm curious if you guys are going to 1 month in any patients, especially the stable ischemic heart disease, or you're still waiting?
We're typically not yet. I think you need to see more prospective data, particularly at high-risk bleeding patients. But there's data like that, like senior, does give you a little bit more comfort in people who have to stop.
Yeah,
Because
some
people,
come in with a complication,
have to stop, and
better,
then you feel okay about it. So that expanded pretty well, and I think you sized it perfectly, landing it distal to the diag, so you're not going to double jail it. Deliverability seemed very reasonable.
Worked out great, yeah. And so now we're going to stent from that, hopefully all the way back through the left main here.
So I think one of the really important things for people who don't do a lot of atherectomy is imagine doing this case with balloons only. I think it'll get you to start thinking more about rotablator. This would have been a 4 or 5 hour case in a lot of labs.
It's interesting. There are only 2/3 of the labs in the U.S. actually use atherectomy, and that's despite the fact that we know patients are getting older, they're more complicated, they have more comorbidities, and we're doing more surgical turn-down type cases. So I think there's clear underutilization, in my opinion. The overall rate of usage of atherectomy is around 5%, despite the fact that these comorbidities are increasing. And so that's one of the reasons, as you know, there's an ongoing randomized trial with the CSI atherectomy device versus conventional balloon angioplasty or specialty balloons to try to show this, because I think those of us who have done this for a long time know exactly what you're talking about, where you don't do it and we hit roto-regret. But I think it's important to try to prove it, so hopefully we'll be able to contribute to the scientific evidence base by doing a trial like that would then allow there to be more reason for people to understand how to do these things.
No, I totally agree. I think you need to know what's in your toolbox. There are other hospitals that don't have atherectomy. We had a case like this referred in, and fortunately the operator decided that he was going to wait and send the patient for atherectomy rather than continue to try to flog forward with multiple calcium issues and then get a suboptimal result, because an extra 15 minutes in the lab to do the right thing means a lot for the patient for the next decade.
And the challenge is there are many safe operators out there who wouldn't even flog because they know that could dissect the vessel, and what they do is they just opt medical therapy. And that is challenging for patients who have indications for revascularization. So I think for anything, it behooves you to know all the tools that are out there and to be facile at them, and then to use them appropriately in indicated patients.
So it's a little bit difficult visualizing where the stent ends in this. So we just did an IC stent, and I think we're just overlapped enough. This is a 3.0 by 38, and then we'll have to put one additional stent in the left main.
The one thing you can do sometimes is that if the 3.5 expansion criteria are greater than the 3.0, you can kind of under-deploy a 3.5 and then really flare the proximal more. But if you're going to put another stent in the main, that's okay. You may not need it, though. I'm not sure.
With the synergy, the 3.5 and the 3.0 both go to 4.25, so I think you're going to have plenty of room with the 3.0.
Yeah. We couldn't quite reach the ostium with the 38.
But by the IVUS, the ostium didn't look that bad. It's totally up to you. We just looked at it kind of cursorily, but
Well, you can IVUS it. You're going to IVUS it anyway at the end, so you can take a look.
So here's I don't know if you can switch over to the IVUS. You want to put the IVUS up live? Is that possible?
Yeah.
Then I can, there you go. So this is the ostium of the left main here coming out, and as we're going into the vessel.
It's a pretty big shelf.
Yeah, but it's a nice, I mean, if you were to measure the area there, it's
so the
pretty,
MLA is pretty good.
yeah, it's pretty good, so you may be
And
okay.
there's the circ coming into the north, and there's the ostial
Yeah.
LAD.
We might be able to just take a look here and see.
I might re-IVUS it and see what it looks like. Because that area, because of that asymmetric calcific shelf, it looks tighter, but the area is probably, you know, when you measure that, I bet you that's, you know, 7 or 8.
Pretty good.
Probably 7 or 8.
But what about the
Yeah,
ostium?
7
There you go.
or so.
So we're gonna re-image, I think.
Yeah, I think important to reimage there and reassess that
You may
left main. The diagonal stayed open, which is good.
It looks great.
And the flow is very good.
Right here, guys, is the IVUS image of the ostium of the LAD. I don't know that our stent got back here. That's
Want to go call out, please?
I think the easiest way is just to run the IVUS down, and then you'll know. But you might want to post-dilate it first, because when you're through that much tortuosity and calcification, if your IVUS butts up against things, then you run the risk of distortion of the stent platform. So maybe NC first, re-IVUS, and you may be good.
Yep.
It's just an asymmetric calcific shelf there, which is why angiographically it looks funny. But you can, instead of taking multiple views to sort it out, definitively know by the IVUS. So just so you know, we have 5 minutes remaining in the transmission. It's been actually great because you've done the case safely, got stents in, expanded them well, because it's not just about delivering, it's also about expanding the stents. You know, we'll keep watching you. Any other thoughts from the panel, Carlos, anything like that?
No, I just think that they did a very nice job, particularly all the points that were made at the beginning of the live case in terms of hemodynamic support. It shows and proves the fact that these complex cases can be done, should be done, and there's no reason why patients should be denied therapy like this. You just gotta be thoughtful and understand the potential ups and downs about a case like this and try to anticipate all the potential issues as they have done. So I think it's a really nice demonstration of what we can offer nowadays to these patients. For her in particular, I'm happy because it changes her outlook.
I mean, this completely changes her prognosis.
Totally.
By making her eligible for the transplantation. And I mean, if you were to make the argument and say, well, she didn't need this, she should be able to go for the transplant. Well, try arguing that to the transplant team and see where that gets you. So.
Very hard.
one regret we had is we probably just were a little too aggressive with our roto early on. We probably should have given her a little break between those runs.
But I think, you know, you recognize that you managed it well. But I think, you know, as Jason mentioned, in between the runs, you can give vasodilators and sort it out. But here, this is you know, great lesion prep. So pre with atherectomy, pre with ballooning, post with post-ballooning, and you're going to maximize your minimal stent area and outcomes for her, because she's going to stop her DAPT, I'm sure, early in anticipation of transplant. And so without this imaging-guided post-dilatation approach, you'd be a little bit more worried about it, whereas I think you can feel more confident this way.
I think one of the things that was really nice with this case
I
is...
totally agree to Jay. I think the issue that comes up is really not asking when you should image, it's really why not.
Right. I think this case really highlights the fact that you didn't skip any steps. You didn't skip the rotational atherectomy. You didn't skip imaging. You didn't skip pre-dilatation, and you didn't skip post-dilatation. And when you start trying to skip steps, that's when you get into trouble, get suboptimal outcomes, and actually increase the length of the procedure.
So we're running up on, it said 2 minutes on the thing. So maybe just a quick IVUS run?
Yeah, that would be great.
That's next up here. We'll get
All right.
that right down. I think we're going to have to post-dilate more. That was at 3.0 to high pressures, 20 and 24, but I think that it's too small.
Just be careful with that. That back, that's all bent up already.
All right, so we just bought a little bit more time. We do have a hard out at 20 after, so I think that'll give us enough time to see this IVUS run and to go from there. We do understand you got to post-dilate the prox vessel as well.
Go ahead, Glenn. You want to put it there? Glenn.
One thing to consider when you're doing this with a safety sheath in the groin is, especially on anticoagulation, is do intermittently check that sheath because you can bleed around it, it can kink, and things can happen. So just good practice. And it's also why it's nice to have two operators for cases like this, because stuff like that sometimes gets forgotten and other steps get forgotten. And so if you go back and forth, it can help you.
So one quick note for the audience. They use the new RotaPro device, which was approved last fall. And the Boston folks here have been really gracious not only to support this case, but they also have a wet model that's available to be used. And so if you don't have the RotaPro and you want to check it out, it's a great, they've got a great model, and you can actually try it out on the wet model.
Unbelievable, huh?
Yeah.
That kind of tells you you probably need to go 3.5 in the proximal LAD. And
Yeah.
but
Try it again. I'm just going to change the angle on this.
Yeah, change the angle of the gun.
So the idea here is you try a little bit, and if the IVUS doesn't cross easily, you just take it out and then just post-dilate, because this is where if it's catching on the edge of that stent and you push, you can just completely compress the stent and have all kinds of misery after that. So yeah, I would just post-dilate though.
yeah, there are times to push harder. There's
Yeah,
times
the
when that
axial
pushing
strength is not-
is telling you to stop pushing.
Yeah, especially after all the work that you've done. You don't want to screw up the last second.
And remember, the synergy stent is it's reinforced at the proximal end, and that's a modification that was made initially. But the truth is any stent, if you push hard enough, you can do things to it. So it's much better to just go in, and he'll have a new balloon now and be able to modify it.
Yeah. That's what we're going to do.
Sorry, we couldn't get you another IVUS there.
And now your setup here was this is through you did it through a 6 French radial or a 7 French radial? What did you use?
6 French radial.
6 radial for both of these cases.
Yeah. And minimizing complications that way, I think, is pretty important. Some would say, oh, for rota you need 7. You don't. Anything up to a 175 burr, depending on the guide you use, you can do through a 6. The challenge with a 175 burr, though, and a 6 is it's hard to test puff around the burr, but it definitely can be done, and it can be done radially.
It's also challenging because you'll lose pressure. Your waveform gets dampened, and so it's a little bit hard, particularly in somebody who has soft blood pressure, to really know where they're at hemodynamically.
And the sheath.
I also think the advantage of 7 radial too is quite good, because you can do simultaneous stents as long as they're not very large, and you can get the 175 burr. And the 7 slender sheath really is pretty well tolerated by most people. I mean, she's very petite, and the 6 is quite easy in her.
Yeah. I tend to like using the 7 for left mains. In this case, the circ is subtotally occluded, but the reason is that if I get a balloon dissection that then compromises the big major side branch like the circ, you can bail out to a 2 stents at the same time strategy, whereas through a 6, that's a lot harder to do. You have to do a balloon and a stent. But in this case, it was great.
I think anytime you're doing a bifurcation where you're going in with an upfront 2-stent strategy, I really think 7 French is just going to save you a lot of time and heartache trying to battle getting 2 balloons through, 2 stents through, et cetera.
Yeah, and even you brought up the dual lumen catheter earlier, but trapping that out in a 6 is really tough if you can.
Anybody using sheathless guys?
I mean, I think we heard it in some other sessions, some folks doing it. I don't do it routinely because the 7 slender is so good. But it certainly can be done. There are also modifications like the railway system that you can get in larger guys with a different type of dilator, sheathless. But I haven't.
Yeah, well, the railway only comes up to a 7 French, and so usually with a 7 French sheathless, the railway doesn't buy you a whole lot. If they had an 8 French, then potentially it could be useful. I don't have a lot of it. I don't have any experience with the OCath, but I know a lot of people like those because they can get a 7.5 or an 8.5 French through an arm. But you may sacrifice a little bit on guide support.
Yeah, 7.5 is the max that OCath goes. The challenge is it's a very stiff catheter, the dilator part, and so you got to be a little careful. So we're really running short on time, and I don't want to lose you. So I just first want to thank you all for a great transmission, really great demonstration, calm, peaceful, but very complex lesion. So it was fantastic to be here on this end and to watch it. I think you're going to take a picture here, so we'll see exactly what that result was, which is great. You'll IVUS the left main and just be sure that that looks fine. Again, just an honor to be here. I'm sure Carlos is very happy because it's his clinic patient, and he's sitting here smiling. So thanks again, and we'll give you a hand.
Well done.
Very well done, guys.
Now, really quick for the audience, there are surveys around. We definitely want to get a sense of what you thought of this, because this is a little bit unusual format to do a live case for a lunchtime type of symposium. We covered a lot of topics, but I think it was pretty meaningful and helpful to be able to do it, but we'd love to see if you agree. So please fill those out, and we take them seriously. And thanks again to BSC and also CVI for hosting this transmission.
Yeah.
Thanks, everybody.
Pressure's pretty good.
No, we're good. We're off pressure. We're not. I would go by her.
Yeah, I mean, she runs around 100. That's her.
I would start coming down a little bit on that.